Hello guys, welcome back. This is Dr Ranjith, your pathology educator at Unacademy. So here we are with one more pathology nugget. I think this is 12th of the series of lectures for postgraduate students, and we are seeing in each and everything one unique organ system and a unique case and discussion, right? So what we are going to do here is the same. I'll present to you a series of cases, and I'll propose the differential diagnosis, and all these are completely worked up cases, and for most of them I do have the IHC findings as well. I'll show you the IHC findings, and then we'll come to a complete diagnosis and maybe a few words regarding the same case, so that if it comes in a viva for you, you'll be able to tackle them, and then pathologist perspective of how you are going to approach to a case and to make a differential diagnosis, right? And to start with, we have a very unique series of lectures for postgraduate students for pathology in the Unacademy app. I want you to just go through it and please use it for yourself, and all these lectures are free of cost. Hopefully in future we'll be able to make more contents with your inputs, and let's make pathology education much better. Fine. So with that note, we'll start today's lecture. Today's slide. It's a 30-year-old person with a salivary gland mass. Salivary gland mass, a 30-year-old, the first thing for most of us what will strike is my pleomorphic adenoma, right? At least I'm not going to give you such a simple lesion for you for a case discussion, right? So let's go ahead with the image. I think there are 4 images here and one IHC. Fine. That IHC is going to give you a clue that it's not a simple case, because for a salivary gland mass, generally we don't use much of an IHC, right? So we'll look at the first image. This is the first image. There are 2 10x images and 2 20x images. Fine. So first image, if I look at this image, one thing which is striking for me is this lesion. I'm having definitely defined fibrotic areas, right? Here as well I can see fibrosis, here as well I can see fibrosis. I'm having lots of fibrosis, and there is totally blue here. I couldn't appreciate what they are, but an entirely blue lesion. Few of my differential diagnosis, it could be hematolymphoid again, or a very primitive lesion. Primitive lesions is unlikely in an salivary gland tumor, but could be hematolymphoid, because salivary gland tumors, salivary gland can turn into an lymphomas. I'm sure you must have heard about Sjogren's. That's a risk of a lymphoma, or it could be just a Sjogren's when florid inflammation. That's also possible, right? We'll go and see what this is. The second image here, again, the same thing. We are focusing in a different field. What is more prominent for me is fibrosis, and definitely yes, these looks like an hematolymphoid lesion only, right? Because there are lots of blue cells here. Again, I'm not able to make what they are. We need a higher power image. We'll look at the higher power image soon. So this third image, if you can see, I'm just going to concentrate on this. You can see the residual duct acini unit retained here of the salivary gland, and this lesion is kind of pushing between them, right? They're just kind of infiltrating and pushing them. It's not primarily the lesion which is going to affect the, it's not replacing it. It's kind of coming inside and destroying them. So one thing I can say that is, it's not coming from the salivary gland per se, because if it's from salivary gland, these structures would have been destroyed by this time, right? Let's assume an acini becomes a mass, it will definitely destroy everything in the surrounding. So here there's something coming from outside and infiltrating, which is also causing fibrosis. If it is a lymphoma, it will be difficult for me to explain fibrosis in a lymphoma unless it is nodular sclerosis, but it doesn't look like that, right? The cells I see here, if I can concentrate on these cells, though it's a low power image, I'm sure if you concentrating on this, most of the cells here have plasmacytoid morphology, right? They are plasma cells to be specific. Fine. Let's see one more image. Definitely they are plasma cells, and you can see these macrophages as well, right? Lots of them are plasma cells here. I don't have much of an atypical cell. I do have lots of plasma cells here and fibrosis here. It's a mass lesion, right? So now I want you to think about this differential diagnosis. Whenever you see in any lesion, a mass forming lesion with fibrosis in the microscopy and a dense lymphoplasmacytic infiltrate, this should ring a bell. You have to suspect an IgG4 mediated disorder, because of late this has become very common that almost every organ can have an IgG4 mediated diseases, right? I'm sure you must have had short topics on that in your post graduation, right? So we did go about IgG4, and this was how it is positive. It is entirely positive, almost like the criteria says that it should have more than 10 IgG4 positive cells per high power field. It's definitely more than 10. It's uniformly positive all over, right? So we reported as an IgG4 mediated disease, and we asked for the serological evidence to make sure I can put into a defining criteria, because IgG4 mediated disorders are defined by criteria. I can have a definitive diagnosis, probable, possible, and not IgG4. Based on that, I need both clinical, I need serological evidence of IgG4 levels, and also I need my histopathology. Histopathology here is perfect. I do have the classical fibrosis. It's called as a storiform fibrosis. Storiform looks like this. Though I don't have the storiform lesion here, I should have taken a much lower power image. But yes, I can see fibrosis which are dividing the lesion into septations. So kind of a storiform lesion. And I do have the IgG4 positivity here with dense lymphoplasmatic infiltrate. So my histological criteria is taken care of. So I need my serological criteria of IgG4 levels and the mass lesion. That also then my question, right? So let's see how to diagnose them and where all I can see these lesions. This is from a Nature's journal. I can see almost in every condition, right? You can see here frequently seen, occasionally seen, and infrequently seen. Maybe infrequently seen I can knock it off, but still thyroid, it's still a possibility. You must have read about something called Riedl's thyroiditis that's been reclassified into IgG4 mediated disorder, right? And in your meninges as well, I can see them. In aorta as well, I can see them. Again, these are all rare things, especially when I'm seeing an aortic aneurysm. The abdomen aortic aneurysm has been differentiated into inflammatory aneurysm and atherosclerosis induced aneurysm. And most of the inflammation are due to IgG4 mediated pathogenesis, right? And it's occasionally seen in your extraocular muscles, and you can see in the lungs occasionally, biliary tract occasionally, and especially in the pancreas, I can see them, and I can see them in kidneys. And they are frequently seen in, like in our cases, major salivary gland. Salivary gland is one of the frequent locations of an IgG4 mediated disorder. Pancreas especially. The second type of autoimmune pancreatitis is IgG4 mediated. This becomes very important because most of the pancreatic lesions, when I see a mass in the head of the pancreas, clinically my first diagnosis is going to be in tumor, neoplasm. IgG4 mediated disorder are also mass forming lesions. It's good for the patient. It need not be a pancreatic cancer always. So biopsy diagnosis becomes more imperative in case of a pancreatic mass, and it's one of the lesions, as per the Nature's journal, it's frequently involved with IgG4 mediated disorder. Retroperitoneum, again an important thing. Anything big in the retroperitoneum, our first differential diagnosis as a surgeon is sarcoma, right? And if it's an IgG4 mediated disorder, like an Ormond's disease, it's classical for me to diagnose an IgG4 mediated disorder. The reason why this becomes very close DD for a neoplasm is it can form a mass. Second, it can form desmoplasia, fibrosis. If it's cancer, that also can form fibrosis. So the mass looks a bit firm on palpation. If I can palpate, like in salivary gland, or even a radiology, they'll pick up the fibrotic lesion. So it becomes very close differential diagnosis for neoplasm, clinically on examination, as well as on radiology, where microscopy is going to totally give a totally different outlook, and you have to be able to pick these lesions up. And it's also common in black rectal cancer, right? So all these are spectrum, and it's ever evolving. I can have them in the penile lesions as well, Peyronie's disease. That's an IgG4 mediated disorder, right? As I said, it's ever evolving thing. So make sure whenever you see fibrosis, lymphoplasmatic infiltrate, think in this line. And the diagnosis goes like this. I'm going to have three things inputs. One, clinically, organ involvement. It should be dysfunction, and a swelling is must. Either it could be localized or diffuse swelling, but swelling is must. And a biochemical evidence of greater than 135 serum IgG4 level diagnostic. And I said histopathology. My microscopy of storiform fibrosis, phlebitis, dense lymphoplasmatic infiltration, plus your IgG4 to G ratio 0.4, or as I said that more than 10 cells of IgG4 positivity per hyperfield is also enough for me. When I see all these three of them, I call it definitive criteria. Any other organ specific criteria, we'll see other than Miculous disease, about them later, fine. That's also definitive for me. When I will call it something probable is, my serum is less than 135, my serum is not contributing, but yes, definitely is an organ involvement with dysfunction with a mass lesion, and my histopathology also is diagnostic, I call it probable. Again, I want all three to call it definitive. If one is gone, I call it probable. But when histopathology is not available or not diagnostic, it becomes possible diagnosis, right? So I cannot diagnose an IgG4 mediated disorder with confidence without the presence of histopathology as on date. So histopathology becomes extremely important. So if your hospital doesn't have an IgG4 IHC, please convince your head to procure one, because it's ever evolving. And again, I'll tell you the reason why I need to give a very specific diagnosis. When it's no IgG4, no histopathology, only an organ involvement, it means never, right? So it can never be diagnosed clinically. Yes, though it can be suspected clinically, I need a lab's help to come to a diagnosis of an IgG4 mediated disorder. As I said, why is it so essential for me to diagnose an IgG4 mediated disorder is the question. See, what has happened over the years is, it's an autoimmune lesion, that's all, right? So what I've done is, when I'm saying any autoimmune lesion, I didn't have a perfect approach, or I couldn't diagnose it with confidence. I can diagnose an autoimmune disease. When I'm going to treat, I'm going to give steroids or any immunosuppression. Now I have bifurcated saying that these diseases are primarily due to an IgG4 mediated plasma cell. So if I can stop the plasma cell from producing this antibody, I can revert the entire lesion. At least I can try to. So this is more specific etiology. Whenever I know an etiology, my only goal is to make sure I can treat the patient with confidence, that's all. So when I have this, there are set criteria for each of them. Like there are CNS IgG4 mediated disorders as well, which responds the first line of therapy there is rituximab. So give a B cell marker, inhibitor, CD20 anti, so destroy or knock off the B cell, so a plasma cell can never come. When a plasma cell is not there, definitely the disease is not going to progress, right? So there are very set criteria for each and every organ, where the treatment with the specific drug as mentioned will give an amazing response. So it's not just an autoimmune disorder, it is an autoimmune disorder for which I know, okay, this is how the disease is going to progress, and I know I can diagnose it with confidence, at the same time a better management, that's all. So it's going to be extremely helpful for the physician, a rheumatologist or an immunologist who going to treat the case. So I want all the pathologists listening to this to be very confident in diagnosing IgG4 mediated disorder, fine? So that's about today's case, and I urge you to just go through the profile. Under my profile there will be lots of cases and case discussions and classes for postgraduates of pathology. Hope it will be helpful for you. I've divided endometrium and cervix, and we're done with both of them. And as I said, this month we'll be covering ovary as well. So that those are my bread and butter in your day-to-day practice. So if it helps you, great. And all the classes which is hosted on the Unacademy platform is free of cost. You can watch it anytime. You can download the lecture loads as well, and you can watch it online or offline. If it's online, we'll discuss together and we'll go together. Fine. Thank you for your time. See you soon with another video. Till then, bye bye from Dr. Ranjith. Bye bye.